Hello, this is Paul Bunch, and I'm pleased to provide this short video summarizing what the surgeon wants to know from the radiologist when referring a patient for parathyroid CT. I believe that by understanding a little about the surgical perspective, then we can spend more time assessing what matters to them on the imaging and less time worrying about what doesn't. I have these financial relationships in addition to my employment at Wake Forest. What I want you to know about parathyroid hormone is that it acts through various mechanisms to increase serum calcium. When an intrinsic abnormality of the parathyroid glands results in excessive secretion of parathyroid hormone, this is called primary hyperparathyroidism, and this is the type of hyperparathyroidism with which this talk is concerned. In the interest of time, I'm going to assume you already know or are willing to accept the following facts. Primary hyperparathyroidism is diagnosed biochemically, primarily based on serum calcium and serum parathyroid hormone levels. It is most often caused by a single parathyroid adenoma, meaning a one-gland problem. However, it can less often result from an abnormality of multiple parathyroid glands. Primary hyperparathyroidism is cured by removing the abnormal parathyroid tissue, whether that's one or multiple glands. The reason for imaging is to localize the abnormal parathyroid tissue that the blood tests have already told us is there. There are two accepted parathyroid operative strategies, and I think it's worth knowing a little bit about both. The bilateral neck exploration is the original operation and involves the surgeon's visual and tactile inspection of all the parathyroid glands. The glands judged by the surgeon to be diseased are then removed. Bilateral neck exploration involves a relatively large midline incision, and because it's a bilateral operation, both recurrent laryngeal nerves are at risk for operative injury. The good news is that there are excellent long-term cure rates with low morbidity in experienced hands. The minimally invasive parathyroidectomy is a newer operation and the preferred operation when appropriate. This is a single gland operation, and as such, a prerequisite is confident and precise preoperative localization of a single adenoma. This operation has been well studied by the surgeons, and demonstrated benefits relative to bilateral neck exploration are summarized on the slide. Importantly, the cure rates with the minimally invasive approach are equivalent to bilateral neck exploration for well-selected patients in experienced hands. To recap, primary hyperparathyroidism is most commonly a single gland problem, but can occasionally be a multi-gland problem. There are two acceptable operations, one of which is a single gland surgery and the other a multi-gland surgery. Not surprisingly, the surgeon is interested in matching the correct operation to the correct patient. And to select the appropriate surgery, these are the things the surgeon wants you to address. And they're fortunately pretty straightforward: number, size, and location of candidate lesions, and your opinion of what each candidate lesion most likely represents. It's intuitive that a single lesion is more likely to represent a parathyroid adenoma, whereas multiple lesions are more likely to represent multiglandular disease. But what about in the setting of no lesions? Well, the patient still has the disease because the biochemical results haven't changed, and they still need surgery to remove the abnormal tissue that the biochemical tests tell us is there. However, in the absence of a target on imaging, bilateral neck exploration will be necessary, and there is also evidence that these patients with non-localizing imaging are more likely to have multiglandular disease rather than a single adenoma. Now let's assume we have a single lesion. The bigger it is, the more likely it's an adenoma, and the patient will be cured by minimally invasive surgery. However, a patient with only one lesion found by imaging is statistically more likely to have multigland disease rather than an adenoma if that lesion measures less than 7 millimeters in maximum diameter, such that bilateral neck exploration will likely be necessary in this patient subset. In an attempt to provide the surgeon with a roadmap of the patient's neck, I tend to provide rather detailed location descriptions, and I try to use the landmarks that my surgeons tell me are most helpful. These are a few of such landmarks, and I'm going to expand upon the first two. From the standpoint of the anatomy and embryology, I want you to notice that as viewed from the front, there appears to be a lot of overlap between the distribution of superior parathyroid glands outlined in red and the distribution of inferior parathyroid glands outlined in blue. But something interesting happens when we view the same anatomic information from the side. The superior glands cluster posteriorly within the neck, and the inferior glands anteriorly, and the line of demarcation is formed by the plane of the recurrent laryngeal nerve. Now, we of course cannot see the recurrent laryngeal nerve by CT, but its location is approximated by the plane of the tracheoesophageal groove. Thus, by describing the position of parathyroid lesions as anterior or posterior to the tracheoesophageal groove, you are not only telling the surgeon whether it is an inferior or superior gland, but you are also giving important information as to the risk to the recurrent laryngeal nerve during the operative approach. With respect to SI orientation, my surgeons have asked me to describe lesions with respect to the cricoid cartilage, rather than cervical vertebral body level as I used to do. My surgeons find the cricoid cartilage to be a useful landmark because it is consistently palpable, routinely visualized in their standard operative field, and orients them to the anatomic midline, which I'm told can be surprisingly difficult to figure out in the reoperative neck. Refreshingly, the surgeons want to know what we think each candidate lesion represents. If presented with high and low confidence lesions in the same patient, they will often start with a minimally invasive approach to the high confidence lesion and plan to convert to bilateral neck exploration if the intraoperative parathyroid hormone levels do not drop as expected. Practically speaking, if you can't confidently determine that a structure is thyroid, a lymph node, or vascular, I'd suggest describing that structure as a candidate parathyroid lesion in your report. The classic enhancement pattern of parathyroid adenomas is well documented, but it's less publicized that this classic pattern is only seen in 20% of adenomas. Thus, I'd encourage you to keep an open mind as to what a parathyroid adenoma can look like, including cystic foci, fat deposition, and calcification. So that covers what the surgeon needs to know from us to select the most appropriate operation. I want to also touch on two things we should look for to keep the surgeon, and by extension the patient and ourselves, out of trouble. No surgeon wants to perform the perfect parathyroid operation and leave a thyroid cancer behind. So acknowledging that CT is not the ideal way to characterize thyroid nodules, if you notice something potentially worrisome in the thyroid gland on parathyroid CT, you should alert your surgeon so that they can, at a minimum, get a preoperative ultrasound, possibly also a fine needle aspiration, and if necessary, potentially perform a concurrent thyroid resection at the time of parathyroid surgery. The other thing we want to look for and report are arterial anomalies associated with a non-recurrent laryngeal nerve. In the normal situation, the right recurrent laryngeal nerve arises as a branch of the vagus nerve after the vagus passes anterior to the right subclavian artery. The right recurrent laryngeal nerve then loops beneath the right subclavian artery and ascends within the right tracheoesophageal groove to reach the larynx. What accounts for this normal relationship is an embryologic link between the right subclavian artery and the right recurrent laryngeal nerve. In the setting of an aberrant right subclavian artery, this embryologic link is broken, and the result is what is referred to as a non-recurrent laryngeal nerve. Both the branch point from the vagus and the subsequent course of the non-recurrent laryngeal nerve to the larynx are variable and therefore unpredictable. As a result, there is increased risk of operative injury to the nerve, particularly if the surgeon is not alerted to its presence preoperatively. Thus, for any patient having thyroid or parathyroid surgery, I choose to report the presence of an aberrant right subclavian artery in the impression. I should mention for completeness' sake that the same is true for the left recurrent laryngeal nerve in the setting of a right aortic arch with a aberrant left subclavian artery, though this is, of course, far less common. So wrapping up, this table summarizes each item we've discussed and why it is important to the surgeon. I won't read it to you, but you've got it to refer to if you'd like. Once you understand what the surgeon wants to know, it's relatively easy to develop a report template addressing each piece, and something like this is what I use in my practice. Feel free to do the same in yours. Okay, so what are the take-home points? Well, I think it's critical that you understand that primary hyperparathyroidism is diagnosed biochemically and cured surgically. The role of imaging is preoperative localization, and it is my belief that by accurately reporting what the surgeons need to know from parathyroid CT, we as radiologists facilitate the best possible operative plan for each patient. If you'd like to read more on this topic, much of the material presented in this video is drawn from these two papers I worked on with Dr. Hilary Kelly. I also highly recommend this paper in radiology. Thank you for watching, and I hope you learned something.